we've got Luke up next. So Luke Herbert from Surrey and Sussex Healthcare NHS Trust. So Luke, again, another one of our clinicians I mentioned earlier, and Luke's going to be talking about his work at modelling eye injection pathways.
And hopefully you have me there. Yes, you do. And can you hear me okay, guys?
Yeah, I can hear you fine.
Lovely. I promise no eye injections are involved in this presentation.
Just to say, I don't know if it's just me, Luke, but your screen is tiny. It's in your little your window. Is it just Sammy? Is it just me?
It looks the same for me as well. I'll just see if we can spotlight Luke, if that works.
Yeah, there we go. That seems to work.
Lovely, thank you. So I'm an eye surgeon, and since HSMA, I'm now an amateur coder. And I basically joined HSMA because I wanted to do this project. And I wanted to thank Sammy and Dan, or Danny and Sam, as I keep on calling them, for all their help with HSMA, which has absolutely been fantastic, been a great 16, 18 months. And also my peer support group, Z80, absolutely fabulous. And as well as that, my trust, who've actually supported me very, very much through this. So wet AMD, or neovascular AMD, it's a nasty disease. Going to give a little tiny bit of clinical background. These images at the bottom are some scans of the back of the eye, and the red dots, not the pink ones, but the red dots are blood vessels growing where they shouldn't be growing. And the left-hand side, the bottom, is an early picture, and the right-hand side is a later picture. This is actually the same patient, about 3 months apart. And the chart on the top right gives you an idea of a sight test chart. So the little tiny letters at the bottom that you can't see, even though I'm magnified now, would be our normal vision, as it were. The line above it, twice the size, is the threshold where we can start treating for this condition. And the very top line, that would be huge if you imagine it on a sight test chart, is the level at which patients' vision falls if we don't treat them, and in fact the level at which we stop treatment. At that level, that's 20 letters, because we measure things in letters, so to be reading 20 letters at that level, you probably can't recognize faces, and that's the natural history of the disease. The biology is that the aging eye produces essentially a fertilizer, which makes blood vessels grow. And for many years, we tried to do lots of things to get rid of these blood vessels, and none of them ever worked because this fertilizer was still there, this VEGF stuff. And when I was a junior doctor, if somebody had this condition, you basically offered them tea and sympathy. By the time I was being appointed as a consultant, there was hope on the horizon with some drugs which can get rid of this VEGF chemical. And so there are antibodies or similar molecules that bind the VEGF and essentially mop it up and take it away from the eye. However, they have to be injected in the eye, and the molecule is cleared over time. And so they require repeated injections. And the first molecule we had to be injected pretty much every month. We have different molecules now that last a bit longer, but the optimal frequency still isn't really known, and it's certainly not known very well for individual patients. And our patients are quite difficult to look after. A lot of them stop treatment. They're elderly, so they obviously have a significant mortality. They're sometimes frail or too unwell to attend monthly or bi-monthly appointments. The vision will deteriorate despite treatment in other people. And the NHS capacity, not least the capacity to phone people up and make sure they come along to clinics, is limited and limits appointment availability. And so we end up with a discontinuation rate in the best trials, of 40 or 50%. And in the real world, it can be a great deal worse than that. There are also 1.3 billion reasons a year to worry about this. And that's the estimate of what the cost will be, £1.3 billion a year in about 5 to 10 years' time. It's not quite reached that yet, but the NHS annual treatment costs for wet macular degeneration exceed that for cataract surgery and exceed that now for hip replacement surgery. And it's actually not much of a bargain. It's a very expensive per quality adjusted life year. The main drug that we use is around £800 a dose list price, but there is a generic coming out soon, so the price will fall, and that may well change the way that we use the drug. And that's part of the stimulus for doing this. So why model? Well, we're modeling because it is a difficult and complicated and tangled evidence base, and it's very hard to get much information from that evidence base. The real world data is actually fairly poor, and the complex patient pathways make it difficult to just work out simply what our needs are. My main reason for doing the modelling was actually to promote discussion about treatments so that we can use some kind of basis for discussing what might be the best treatment protocols. And by protocol, I mean, do you treat somebody every month, every 2 months, when they need it, when you think they might need it? What's the process? There is a simple NHS England approach, which is basically working out roughly how many people stop treatment each year and then projecting that forward on an Excel spreadsheet. And that's a quick and useful, but gives limited insights for planning your actual service. And so my approach is an agent-based simulation. So that means I'm creating essentially lots of little creatures that run around inside my program doing things. And I can do all sorts of things to what happens to them to try and model them on what I can find out from the real world. The model I've made is quite complex, and it can include many, many different factors, and I'll come into that a bit later on. So if we come to the age-related protocol explorer, this is the structure now. I'm not expecting you to read that, as they say in the lectures, but it's just to give you an idea that what started off essentially as one little box at the top has ended up with pieces bolted on it right, left and center for doing the various analyses and visualizations. Now I'm going to do the most feared part of any demonstration, which is to actually dare to do a live demonstration. I thought, why not live dangerously? So this is actually live at the moment, so wish me luck. So this is our front page, and this is available on Streamlit. I'll give you the link at the end. And the basic idea is that we launch a protocol first of all. Let me try to click the button on Zoom. Never works, does it? Launch a protocol, and we can choose from many different protocols. So I've put a star on a couple of these to remind me to use them today, and then run a simulation. And our simulation can be any size, small, medium, large, whatever. We'll do a large one just to show that it doesn't take ages. And we can configure lots of parameters. I'll come to those a bit more. Once we've run a simulation, once we have that data, so this is essentially 2,000 little monkeys running around inside my computer, having things done to them and doing things over time, over 5 years in this case, we can then analyze what happens to them. We can look at their treatment patterns. In other words, where the flow of the patients is. So this is a treat and extend protocol, which is a fairly complex protocol, which means that patients come in, they all have the same treatment to start with, and then their treatment pathways divide up, and some of them get less and less and less treatment, and then their eye gets worse and they get back to have more treatment and so forth. And this over here captures what happens at the end of our 5 years. We can look at various other things which look at what happens to our cohort. So the gray area at the top of the wedge, so because we're getting patients recruited over time, our wedge is increasing over time, but the gray area at the top of the wedge is showing all the patients who've dropped out of treatment for various reasons. So by about 2 to 3 years, we've reached a steady state of around 400 patients of our total 2,000 cohort being in treatment. And we can also look at the vision outcomes. There's a slight gotcha with the vision outcomes because all studies measure the outcomes at the last time the vision was measured. So people whose vision gets worse tend to drop off the bottom end of this, and you don't actually see what happens to them. And then we can look at the distribution of their vision changes. And we can even look at individual patient trajectories within this. And these trajectories look very similar to the trajectories that I can plot for my patients in my electronic patient record. We can analyze the workload. So we're actually looking at both workload analysis. So what are the appointments that are required for our patients over time? And we can look at that by role, whether it's an injector role, a decision maker, or an logistics assistant, and so forth. And we can work out how many sessions are required, how many resources are required, and what our staffing requirements would be. And we can do a similar thing with a cost analysis. So we can look at the cost metrics, and you can see the thing that dominates it is obviously the drug costs. And if we look at our cost per vision maintained, it's working out on this simulation at around £20,000 per vision maintained over that 5 years. If we half the cost or bring this cost down to maybe 300, which is maybe what the price will be if we're lucky, we can see our cost per vision saved starts to fall considerably. It takes a moment just to pick up. So we're down to £10,000 per cost per vision saved. So this makes a big difference depending on what the costs of the drugs are, obviously, but we can now model that. There's a financial module in here which allows me to assign costs to all the various different things that happen to people, and all of these are controllable, and all the parameters can be savable and exported. And finally, I've got a comparison, so I can compare 2 different protocols. So let me just get a treat and treat protocol. So I've got 2 different protocols here. The one on the right is the treat and extend, and the one on the left is a fixed treatment. So let me just quickly show you what that looks like. So the fixed treatment interval every two months gives a much smoother, and the variable treatment gives a much less smooth. This one on the left is what the NHS recommend at the moment. And actually our costs are slightly less for our fixed treatment, and our vision outcome is about the same. So I apologize for my slight overrun. I will just get back to. So apart from all the various modeling stuff, I have identified within this a lot of variations in practice. This thing is available on Streamlit, it is available on GitHub, but I'm also just building a Docker deployment for it, so any NHS trust will be able to slot it into a Docker deployment and use it for themselves. So as I always say, if you have been, thank you very much for listening.
That's brilliant. Thank you so much, Luke. What a fantastic project, and what amazing potential outcome there. That you know, this could be potentially money saved and patient outcomes improved in such an important area. So fantastic, and I love your app. That's such a wonderful app, such fantastic visualization. So it's been brilliant to see that. Fantastic, thank you. Any comments or questions for Luke? Please do pop them in the chat, but I'll move us on in the interest of time. Also, I should just say, fantastic to see an agent-based simulation project. It's one of 2 that you'll see today as our first year of having agent-based simulation projects. Funnily enough, my very first project when I joined Pencord, when we first started nearly 15 years ago, was an agent-based simulation project around diabetic retinopathy. So fantastic to see that wheeled out again.